anesthesia enthusiasts, and welcome to another episode of Style Points. In this episode, I have not one, but two special guest anesthesiologists from Children's Hospital, Marc Mecoli and Joe Weethee. For all of you sharp-eared listeners out there, you may have noticed the intro had a bit of extra flair to it. I asked Marc to showcase some of his talents on the violin, which he was gracious enough to record for us. Before we talk with them, I'll let my co-host, Nate Moore, introduce this week's RSI, which obviously stands for Resident Selected Information.
Thank you, John. I get to give a warm welcome to Dr. Kat Dunshee, who will be delivering our RSI today. She stopped in between patients in our perioperative care clinic to give us a quick primer on safely combining anesthesia with aortic stenosis. Welcome, Kat.
Today, we are going to be talking about one of the most high-risk valvulopathies we encounter in the OR, aortic stenosis. This episode, we will recap pathophysiology of aortic stenosis, then get into hemodynamic goals and anesthetic approach, and then finish with some practical pearls. Let's get right into the pathophysiology. Aortic stenosis is characterized by an increased left ventricular systolic pressure and an attempt to maintain forward stroke volume through a narrowed aortic valve. The magnitude of this pressure gradient serves as the estimate of the severity of the stenosis. Let's talk about the most severe classifications. Severe stenosis is defined by a gradient of greater than 40 millimeters of mercury or a valve area less than 1.0 centimeters squared. Critical stenosis is defined by a gradient of greater than 50 millimeters of mercury or a valvular area of less than 0.75. As a result of the stenosis, the LV then undergoes concentric hypertrophy to overcome this pressure gradient. This change leads to an increased myocardial oxygen demand, and this makes sense. More muscle needs more oxygen. To make matters worse, myocardial supply reduces due to the marked compression of intramyocardial coronary vessels caused by high intracavitary systolic pressures. We now have an increased demand and reduced supply issue. Now that we've briefly talked about the pathophys, let's get into the hemodynamic goals intra-op. Overarching goals are to avoid hypotension, maintain normal sinus rhythm, and avoid extreme changes in heart rate, SVR, and volume. Let's take a look at these in a bit more depth. 1. Avoid hypotension. In patients with aortic stenosis, even brief hypotension during induction can be dangerous. The left ventricle is already working hard against a fixed obstruction, so its oxygen demand is high. At the same time, coronary perfusion depends on a good diastolic pressure. If blood pressure drops, diastolic pressure falls, filling pressures rise, and the heart muscle can't get enough oxygen. The result, a rapid myocardial ischemia. Next is normal sinus rhythm. The LV is dependent on properly timed atrial contractions to ensure optimal LV filling and systolic stroke volume. Remember, atrial contraction accounts for up to 40% of LV filling. Next, avoid tachycardia. Tachycardia will result in less filling time, leading to decreased coronary perfusion and increased oxygen consumption. Bradycardia is better tolerated but will reduce cardiac output, so a normal or low normal heart rate is best. And finally, preload. These patients cannot increase cardiac output much by SV because of the outflow obstruction. They rely heavily on end diastolic volume. If you let them get even a little dry from fasting, bleeding, or vasodilation, their stroke volume will drop, blood pressure will fall, and coronary perfusion will suffer. That can spiral into ischemia very quickly. That being said, too much volume is also harmful for a stiff left ventricle. Excess pressure will just back into the left atrium and lungs, causing pulmonary edema. Preload in aortic stenosis is a tightrope walk. Our job is to keep them right down the middle. Now that we know our goals, let's talk about the anesthetic approach, including monitors, induction, and maintenance. For monitors, as we know, many of our induction agents lead to hypotension. These patients can crash quickly if their blood pressure drops. Get an arterial line before induction to have continuous monitoring. For induction, be gentle. Rapid drops in SVR with propofol can be catastrophic for a patient with aortic stenosis. You can also consider agents such as etomidate or ketamine with careful attention to heart rate. Overall, slow titration is key. For maintenance, volatile agents are fine. Keep them light to avoid the vasodilation and loss of normal atrial systole. And lastly, pressors. The use of vasoconstrictors like vasopressin, phenylephrine, and norepinephrine are often necessary to preserve systemic blood pressure in the anesthetized aortic stenosis patient. Have them in line on induction. Let's recap the key points to remember when taking care of aortic stenosis patients. 1. Normal sinus rhythm is critical. Avoid the extremes. Too fast shortens diastolic filling, but too slow can also drop cardiac output. Stiff ventricles need adequate filling. Don't let them get dry, but don't flood them with volume. And lastly, maintain SVR. A sudden drop will crash coronary perfusion and cardiac output. Titrate induction meds slow and have pressors ready to avoid hypotension. We often say aortic stenosis is poorly compatible with anesthesia, but hopefully you are now a little bit more compatible with aortic stenosis.
Yeah, it does sound better if you're talking
right
at
on
it like
top of it,
this,
Yeah.
but
Yeah, it's
we can kind of
unfortunately
like get in a little
unidirectional,
bit.
right?
Yeah. I think the correct term you're looking for is cardioid, John.
Jesus Christ.
It'll be in
Get
the
out.
show notes.
You're out. You're
Just
yeah.
the expert here. I can't. I'm supposed to be the guy who knows the sound equipment. You can't just come in here
Dude,
and just show me up like that.
honestly, so one of the bands I'm playing in is we're starting to do our own sound, and I bought this XR18 mixer, digital mixer, which is pretty sweet. It's like I guess this is a mixer, but anyways, I started like watching YouTube videos on live sound mixing, and the rabbit hole that you can go down is freaking crazy.
Well, do you guys want to go ahead and get started?
Yeah, sure.
Yeah, let's do it.
Gentlemen, thanks for joining us.
Thanks for having us.
Yeah, thanks, John.
Absolutely. So let me know how the walkover was from Children's Hospital.
It was rainy.
Yeah, a little drizzly. We got locked out.
Oh, you weren't able to get in with your badge?
That's right. Yeah. Apparently there's like a children's hospital ban on this place or something. I don't know.
We try to keep you guys out as much as possible.
It makes sense.
We don't want you to show us up. You understand?
Well, I had a little PTSD because I went to medical school here.
Yeah.
And I passed by, what is it, E351?
Yeah.
The lecture hall. Yeah.
Yep.
Like, oh my gosh, here we
Yeah.
are again.
Wow. Yeah, I can imagine. I would not want to see my lecture hall again. That would be PTSD for me too.
Yeah.
Is this a required class or is it not a required class?
Well, that's where we matched. That's where my match day was
Oh,
in
really?
E351. Yeah. So the last time I was in that hall was when I opened up the letter where, I was able to match into anesthesia residency.
Well, let me back up for a second because I have two guests here and I want my audience to be able to understand who's speaking. So let me have you introduce yourselves and people can pair your introductions with your voice so we know who's speaking.
So my name is Joe Weethee. I also went to medical school at UC, and I'm one of the anesthesiologists over at Cincinnati Children's.
Yeah. And this is Marc Mecoli. I'm on faculty at Cincy Children's, been there for about 12 or 13 years now.
And Mark actually happens to be pretty much my next door neighbor too,
That's right. Yeah.
which gets you an in to be on the podcast if you want, if you're neighbors with me.
Well, the last time you texted me was trying to figure out where your kid was.
Well, our kids tend to roam somewhat fairly throughout the neighborhood.
Yeah.
So
Free range parenting in our neighborhood.
whether or not they have shoes on or
Yeah.
whether or not they have shirts on, it's just sort of sometimes difficult to ascertain.
That's right.
Well, let me ask you both this question, which is one of my favorite interview questions. If you could have dinner with anyone in the world, could be somebody from the past or even from fiction, who would you have dinner with and why?
So I'll start with that. I'm a musician, so it's for sure will be a musical person. I play violin and fiddle, and I would definitely pick Itzhak Perlman. So Itzhak Perlman is one of the preeminent classical violinists. And when I was a kid playing violin, he was kind of like my hero. He's a really interesting guy who is a child prodigy violinist. And I remember as a kid writing a letter to him, uh, sort of introducing myself and saying, "Hey, like you're my hero." And he sent me back a picture, a photograph of him playing music with Oscar the Grouch on Sesame Street, and he signed it, and I still have that picture at my place, which is pretty cool. But he's definitely a hero of mine, and I think he would be really interesting to get to meet and talk to.
As somebody who goes over to your place on occasion, I'm going to demand to see that next time I go over there.
Oh, there you go. Yeah, for sure.
What about you, Joe?
Mark had that was a very profound answer.
Yeah, well,
I'm not really a musician in the regard that Mark is, but I do like music too. And Mark and I talk a lot about records and musicians, and I think if it could be anyone, I think it would be Willie Nelson. I think he'd just
man.
be a good hang. I don't have a signed picture of him. I didn't write him a letter when I was a kid, but I would love to hear his stories and all the musicians he's played with and all the places he's been. And I think he would just be fun to chat with. I think he would be an easy hang.
So two musical guests. That's excellent. I like that. That'd be great. Would you want to meet with Willie Nelson now or Willie Nelson
Ooh.
from the past? What do you think?
I think that's a good follow up question. I think now,
Mhm.
with all his life experience and all the places he's played and all the things he's seen, talking to him about like, Waylon and Merle and Johnny Cash and all these guys that are passed away now, I think it would be now.
Yeah, think about the stories that guitar has seen over the years. What is it? Trigger? I
Yeah.
think Trigger the guitar. Gosh, can't even imagine.
So you both decided to do pediatric anesthesiology. Why?
You know, that's a good question. For me, I did not come into residency thinking I was going to do pediatric anesthesia. I When I first matched into anesthesia, I really thought I would do like adult cardiac. Um, and then throughout residency, I kind of thought that the ICU was the place for me. And then I trained through the peak of COVID. So when I was an intern, the COVID pandemic started, and I saw a lot, and it kind of shaped me in a way, and I got really good training. But when I was at the end of my CA 1 year, um, my first rotation as a CA 2 was peds, and it was sort of just like a breath of fresh air for me, especially coming from the COVID ICUs where there were lots of sick patients, and it was really refreshing to just to like talk to a kid, ask them about their stuffed animal, get on their level, and it was just way more happy and sort of joyful. And I think those two experiences combined sort of pushed me over to doing peds. But I was not a peds person per se in residency or coming into residency at least.
Yeah, I mean, I always knew I wanted to be a pediatric anesthesiologist from a very young age. No, I it's so weird.
It's Heck Perlman told me I should
Yeah,
be.
it's like, hey, you should.
On your
Um,
Oscar the Grouch picture, I'm sure.
right. So I actually, when I was in medical school, thought I would go into surgery or ENT or something like that, and I I, I really wanted to spend a little bit more time thinking about that decision. So I actually took a year off and did research at Children's through the Department of Otolaryngology and did a worked as a research coordinator on a study looking at fMRI in deaf kids that were pre-cochlear implant candidates. And through that experience, I worked with several of the anesthesiologists and CRNAs at Children's because the kids needed to have anesthesia for their MRI scans. And so I spent the year in that project, and through that experience, got brought up to the operating room. I was like, wow, anesthesia is awesome. So like that, my first sort of exposure to anesthesia was through the pediatric lens. And I just, there was something about the innocence of taking care of kids and, um, the diversity and like, comorbidities and like, there's just something about that I kind of gravitated towards. And then it was through that experience I wanted to go into anesthesia residency. And then that was kind of further, like when I was in Boston at Boston Children's, it just kind of solidified it from there. So,
That makes a lot of sense. I remember when I was doing my pediatric anesthesia months back in Oklahoma, and one of my favorite things was taking care of healthy kids. I
mm,
just thought it was great. Um, I really enjoyed the idea of instead of having to wheel a patient to the PACU, I could just put them up on my shoulder and
yep.
kind of carry them to PACU. And I found that very rewarding. I think one of the trickier parts, though, and part of what made me not necessarily want to go the same route that you did was that there's the whole other side of it too, though, which is the really sad cases, because you
Right.
can feel sorry for and empathize with the 87-year-old who's very sick, who comes in and has a cardiac arrest or something like that. But when it's a 5-year-old or a 2-year-old, it really can be hard.
Yeah,
So
for sure.
I sort of want to dive into what you guys think about that, how you handle it, and what your mindset was for those sorts of things.
Yeah, I mean, I think that there's definitely a certain amount of innocence that you appreciate when you take care of kids, and when you take care of kids with chronic medical conditions, you really just appreciate so much about your own kids' health and your own health, and that is definitely something that you sort of recognize. At the end of the day, in pediatrics, like there is a North Star, and that's the kid that you're taking care of. And it's really cool to see everyone in the room sort of rally behind that. And for me, that's a big part of why I do what I do, because I can feel like, like we're all in this together to help this kid. But it can be incredibly challenging. You see some pretty messed up stuff and some really sad things, but at the end of the day, at least for me, it allows it kind of grounds me in my own life and with my own kids for sure.
Yeah, I mean, I'll echo what Mark says. There are times where the patient you're taking care of that's really sick, you see your kids, they might be the same age
Yep.
or have a similar hair color or whatever, and you see your kid in that really sick kid. And I do kind of turn the situation around, and I empathize and feel sorry for the kid and the parent, but I'm also grateful that my kids are healthy and at home. And like the worst thing that they have to worry about is a stomach bug. And it just gives me perspective, that like it's not so bad, right? And then the other side of it is I think you see the resilience of children too, especially kids with chronic medical conditions who may have a quality of life that's not the same of a healthy kid, but they're just still joyful and resilient. And you see just happiness, shade through their chronic medical conditions. And you see that in adults too. But I think kids just have this like tendency towards joy and happiness. And I think it's actually very refreshing, and it kind of staves off burnout for me, at least personally.
Well, beyond just the joy that you get from seeing kids being kids, I think one of the things that is interesting about pediatric anesthesia is what some kids will come in with, some of the bizarre things that children's do. I remember, for example, when I was on children's call during residency, there was a child who had inhaled a purple straw that had somehow, it was about a centimeter worth of purple straw, and it had somehow gotten below the vocal cords and deployed and was essentially a stent
An airway
right
stent, yeah.
below
You pay good money for
the
those.
vocal cords that caused such an extreme bronchospasm that uh, I think we emptied the Pyxis of all the albuterol in there. It was a pretty wild case. What kinds of cases have you guys seen like that? Crazy things that you might have taken out of an airway or a stomach that would really only happen over at children's?
Yeah, I mean, I think both Joe and I have a very like unhealthy fear of foreign bodies for our own kids. I don't know
Oh,
about you,
sure.
Joe,
Yeah.
but it's like,
Yeah.
oh, everything I see, I'm like, oh, that could definitely be a foreign body in the airway. Um, Gosh, I mean, it's like so common. I'm trying to think of the most interesting thing. Um, I don't know. I will say that when we do foreign bodies for coins, I like to do this thing where we're not certainly not putting an actual wager down, but we do try to pick the coin, pick the year, sort of thing. That's always fun to do. So if you land on like a 1967 penny and you get close, it's like, oh, that got it, nailed it.
There might be
Um,
real copper in that penny too,
that's
so
right.
it might be
Yeah.
worth
Yeah,
something.
exactly. The scariest ones are the airway foreign bodies, obviously, and anything that is expandable, right? So any organic matter is really bad, like a bean or a piece of corn that can, when it gets wet, it can get expanding, and then those can be really critical.
I seem to recall peanuts are really
Peanuts are
bad.
bad, yeah, for sure.
And that's one thing I didn't appreciate, I don't think, until I was a fellow, is just the reaction to the organic
Right.
material that happens, and things get inflamed and very kind of angry very quickly. And that's scary. And then button batteries in the esophagus are always like the most feared. I actually recently went through and like made all my button batteries so
Oh
inaccessible in my
God.
house, because you have to have them, but like I want them far away from because I have a 3-year-old and he does still put things in his mouth, so we hide the button batteries from him for sure.
Yeah, I had the button batteries for my 12-year-old, you know. Yeah.
I think that, I mean, I know you're 12 year
Yeah,
old.
exactly.
Yeah.
I think that's
No,
probably
he's a great
appropriate.
kid.
Yeah.
I took care of a kid recently who was chewing the plastic top of a water bottle and choked on it, and um, he came in and had pretty bad stridor, especially when he was crying. And so we were concerned that it was causing airway obstruction in the upper glottis. And so we got him to sleep, and the ENT went in and looked and didn't see anything. Like, what the heck's going on here? Went down to all the way down to the carina, nothing. Obviously, it was too big to fit down there, but just to make sure. And then all the way in the esophagus, we couldn't figure it out. And I was like, well, he must have coughed it out, but like, why was he still having stridor, right? And the ENT was like, hold on a second. And he reached down into the kid's mouth and then stuck his finger back up past the palate, and it had lodged up above where the palate. So when he was crying, you could hear this like
Whoa.
stridulous sound. And so he pulled it out. I'm like, wow, I would never have thought to look there. And he's like, Mark, I'm an ear, nose, and throat doctor. You know what I mean? So like he figured it out. But yeah, there's all sorts of things you can get stuck.
So a lot of the people that might be listening to this podcast in the future might still be before their pediatric anesthesia rotations. They might not have worked with kids before. I'm curious, from the perspective of somebody who deals with a lot of trainees, like I know both of you do, what are some of your pro tips for dealing with kids in these rather extreme circumstances?
I will say the extreme circumstances are always a challenge. If day to day, I always tell trainees, go in, talk to the parents, talk to the kid. It's a little harder when, if you do have kids, it makes it a little bit easier to communicate with the parents and communicate with the kids, but it also makes the rotation sometimes more difficult on trainees because, again, they're having these experiences where they're seeing kids not doing well or kids having injuries and stuff, and that can be really hard. But if they don't have kids, I tell them, go in, kind of get down on their level, talk to them, ask them about if they've got toys in the bed with them or they're playing a game or a stuffed animal. And I always tell them to just sort of pay attention to how the kid is interacting with them. If they're real hesitant and very sort of withdrawn or shy, I always tell them that might be a kid who it may be difficult to separate from mom and dad. If they're interacting with you and you've developed some rapport and trust with them, that might be a kid that might separate fine and not need a pre-medication like midazolam or something to separate from mom and dad. And it's sort of these like subtle things that are hard to explain or teach to someone, but I think by the end of the month they kind of start to grasp how these interactions are. And then you also have the parents too, right? And so the kid might not be anxious at all, but the parents might be anxious, and the kids do pick up on our emotions and our general aura, is how I would call it. And so sometimes the kid is okay, but when it's time to separate from mom and dad start feeling a little bit more anxious, and the kid might too. And so those are like very subtle, hard to explain things to a trainee, but I say go in there and just get a feel. You're not looking for any specific things. Just go into the room and see how it feels when you walk in there. Is it calm? Is it cool, collected? Or is it like the kid is running to the corner and hiding from you? It's like you start to pick up these things. And I think as the month or two goes on, they start to appreciate those things a little bit better.
Yeah, I will say that in general, to be successful with getting kids through stressful situations, um, giving them very explicit options is important. and not asking them, do you want to do, like, can I put this mask on your face, right? Like if you have a 2-year-old at home and you ask them, do you want to go in the car seat now? Like they're going to tell you no. So giving them options that are sort of directive is very important. And then I think that's one of the challenges of pediatric anesthesia is of establishing rapport with not only the kid but with the parents like really quickly. And you literally are taking their most important thing in their entire life and taking that life in your hands is pretty profound. I mean, you don't think about that so explicitly all the time, but it takes a skill to establish trust and rapport very quickly, in oftentimes a very stressful situation.
So I remember from my pediatrics rotation, I saw a bunch of syndromes that I had never seen or heard of before. They all have proper names attached to them. And while I remember a few of them, at least enough to pass my boards, which is increasingly longer and longer amount of time ago, uh, I still have trouble remembering all of that stuff. My question for you guys is, I'm sure that at Cincy Children's, which is, of course, the number one pediatric hospital, um, you're going to see an extremely wide variety of different conditions that you probably have never seen before or might not have heard of. So when something pops up for your case the next day that you might not have any experience with, what's your strategy for that?
Yeah, I mean, we take care of a lot of really medically complex children. I mean, we've taken care of kids who are one of maybe 10 in the entire world that have a certain syndrome or problem. And then we take care of kids who have problems that are yet to be identified, right? And so the way I sort of look at it is just break it down by body system and really, evaluate the airway, evaluate the cardiac and lung exams, and then just go systematically through all of the body systems. And then certain syndromes are known to have, you know, involvement of different body systems, and so you get to kind of know about what those are and can plan ahead. But just to go through systematically and think about the whole big picture.
Yeah, I agree with that. And I think the biggies that are always tested on are the ones you think of Pierre Robin and Treacher Collins and Charge Syndrome. And you become familiar with those, but you'll have syndromes that are just exceedingly rare. And you're basically reading a journal article to figure out, like Mark said, airway, cardiopulmonary, and then the other one I think about is like metabolic.
Metabolic, yeah.
So you have, lysosomal storage disease and things that may affect, like, should you be using propofol? Should you be using a different fluid or something like that? But those four buckets are probably the big ones you need to hit. And usually there's some sort of description of the process, and then I kind of start to clump them into different buckets. So like the more metabolic, the lysosomal or mitochondrial diseases are sort of in a bucket. The airway disease, syndromes are kind of in a bucket, and I just kind of keep those familiar. But it's not I mean, once or twice a week, I'm probably reading an article or a textbook about some syndrome that I've never heard of or are not super familiar with, and I'm guessing that's going to continue for the next,
Yeah,
10 years.
for sure. And don't forget, you got to figure out what color popsicle the kid wants in PACU too. So
Critical information.
critical information. Yeah, I will say that this is another kind of thing that I think a lot of us really enjoy about pediatrics is that you're constantly learning new things, right? And it's in a like it's a very humbling practice, right? If you're walking into a day where you're like, I've literally never heard of this before, and how am I going to figure out what I need to know, how to keep this kid safe? And it keeps, especially if you've been doing it for a while, it keeps you kind of fresh.
So, what I remember about my pediatric anesthesia rotation is we would sort of religiously make up our rescue syringes in the morning, calculate our doses, and make sure that our weights and everything was appropriate. And I always thought that the pediatric anesthesiologists that I were around were a little bit even more on the control freak side than I was as a as an anesthesiologist. We're all control freaks to a degree, but you guys always had that little bit extra uh, level to you. And I didn't quite understand it until I came upon one of my first pediatric emergency situations, or really more of a mini emergency situation. The prototypical one that I always think of is a bronchospasm. Um, it happened so much more quickly than any adult emergency that I had seen. And the pediatric anesthesiologist that I was with had to respond and figure it out so much faster than I was even prepared for. It was fixed in a hurry, but I just remember it. It was a totally different pace than the rest of what I had experienced in adult anesthesia. And I wonder if you guys could talk through some of those mini emergencies that you might see on a day-to-day basis.
Yeah. So what you're describing is, the laryngospasm or bronchospasm, and I have to say that one of my like kind of key teaching points when people come over and rotate with us is the main difference between pediatric and adult anesthesia is that green bag that's going up and down. And if your right hand is on the bag, you can get so much information by just feeling what that feels like, looking at the patient. And, you know, in some ways, you can almost completely ignore the vital signs in the monitor because you're getting so much information from just being present with the patient. Before I was a fellow, so a long time ago, there was an anesthesiologist who used to shut the monitor off completely during induction because he said there's really nothing that you're getting here that's giving you information in the moment, and it's absolutely true. That wouldn't fly now, obviously, but if you have a laryngospasm, you're going to identify that by feeling the bag going up and down or not going up and down, and having to make a decision before the oxygen saturation changes at all. So you can have a florid laryngospasm and the oxygen is 100%, and you need to have already identified what the problem is and treated it before anything changes. Um, and so that's just like a really good example of how, being kind of in tune and in touch with the patient is really important.
And I think too, with some of those emergencies, when it seems like people are responding so quickly, I think people start to get like an almost intuitive sense. This
Yeah.
kid was sniffly in pre-op. The brother's really sick. That's in the back of my mind when we're going to sleep. So if something is awry, we just start to assume this is a bronchospasm, this is laryngospasm. It's one of the two. And I think we reach for epinephrine and bronchospasm much quicker than in the adult practice, just because they're so heart rate dependent. We're very quickly giving that epinephrine for multiple reasons. But it always works. If the bronchospasm is severe enough, the epinephrine will get in there and get you out of trouble quickly. I think it's one of our cardiac anesthesiologists said epinephrine's like bread. Everybody likes it. And I still tell people that because it's like you can pretty much give it, even in cardiac lesions, most people are going to be okay with epinephrine. It's like bread. Everybody likes
That's
it.
great.
So I still tell the residents that.
Wow. That's an extremely memorable quote. I may have to steal that for my practice. That's great. Um, I'm sure pediatric anesthesia has probably changed since I was doing it a long time ago in residency. What's sort of new within pediatric anesthesia? What have you seen over the past 5 to 10 year period where practice has changed, or uh, I assume you're probably using more Sugamidex now than you probably used to. What else is changing in pediatric anesthesia?
Yeah. So, I mean, I think in general, if you look at all medical specialties, the practice of anesthesia changed very significantly back in the 80s and 90s, and since has been relatively slow to change, right? It's incredibly effective, it's incredibly safe. Um, since my residency, I would say the three biggest changes have been Sugamidex. There's some newer regional blocks that we're doing now that we didn't when I trained. So like erector spinae blocks, IPAC blocks, PENG blocks, things like that. And then I think the biggest thing is the implementation of point of care ultrasound and that how that is applicable in our world. And that's one of my clinical interests is trying to understand how that applies to pediatrics and specifically gastric ultrasound. So we're doing a lot of work with trying to figure out how that can be incorporated into decision making, in MPO violation, and then conditions of delayed gastric emptying and gastroparesis. But that's what's I think is exciting about doing something that there's like a forefront of clinical change, and we're lucky to work in an institution where we're able to explore some of those things.
And I'll piggyback off of Mark. I think the biggest thing with his gastric ultrasound, which now they're sort of pushing people applying for board certification through the ABA, right? It's part of the OSCE now is doing gastric ultrasound. The biggest thing I've noticed a change is in kids with pyloric stenosis. So
Yep.
textbook teaching is you take an awake, 4 to 5 week old baby, and you suction out their stomach awake, which is like the worst thing you can do to somebody, and you tilt them around a little bit to make sure you empty their stomach, and then you cross your fingers and you do a rapid sequence and induction in a 5 week old, which is very nerve-wracking, and you hope that the breathing tube goes in the first time and that hopefully the kid doesn't aspirate and you've emptied the stomach. With gastric ultrasound, we are able to look at the stomach, see that it's obviously distended, empty out the stomach, and then rescan and look to see that it's empty. And then we're able to do sort of a gentle mask induction, which in a baby is much safer. And it has changed. I'll toot Mark's horn a little bit here because he presented some of this stuff at our pediatric anesthesia conference. But I remember hearing someone saying for this particular poster, this is going to change my practice. And I think we don't come across things that often that people say stuff like that. But I know that I have buddies at other institutions that do peds, and I told them about what we were doing, and they sort of, self-taught, and they're like, "This has changed the way I'm
Mhm.
doing these cases." And honestly, it's still one of the most stressful things we do as an RSI on a
Yeah.
baby. It's just very high stakes and very stressful, and whoever's doing the airway is usually a little on edge. We're all a little on edge, but it kind of takes that away, which is huge.
Yeah, that is it's really exciting to hear people say like, "Hey, this is actually going to change what I'm doing in my practice." And we're working on a paper right now looking at um, retrospective review of kids who have had pyloric stenosis and kids that we did gastric ultrasound in and those that we did not. And so we'll look to hopefully publish that within the next year. But basically, the overall findings were that in kids who had a mask induction or a modified rapid sequence induction, had a much lower incidence of hypoxia during the induction. So we called it like a ventilating induction, basically. And it's not new. I mean, Boston Children's published a paper several years ago looking at modified rapid sequence induction in that patient population, showing that it had reduced incidence of hypoxia than more of a classic RSI. But the use of gastric ultrasound was significantly associated with a higher incidence of mask ventilation in that patient population. And so we're hoping that this will, change people's practice and that they'll use it to guide their induction technique in these patients. And we've seen that in other situations too, in kids who have had, sort of an ambiguous or unknown MPO status, and using gastric ultrasound to sort of sort out what's going on. And then it changes our either induction or decision to proceed or cancel a case. And so you can see a kind of real world application, which is really exciting because it's changing kind of, how we practice.
Hearing Joe, you talk about that case stem and having to take care of a baby with pyloric stenosis really just internally made my heart start to race. Just thinking about the prospect of handling that sort of stressful situation. And I handle stressful situations. I see people code. I have to throw in lines in very stressful situations. But I imagine when it's a baby, that was even harder for me to deal with. And that's a lot of stress to carry with you. It's a very stressful profession that you're in. My question is, how do you manage it at home? How do you deal with the come down from that stress? What kind of techniques do you have in your life to uh, just not have a heart attack when you're 35?
Yeah, I mean, I will say that these situations are incredibly stressful. I will say though that we work in an institution in a perioperative environment where, like I said before, the North Star is the kid. And so even when things are going, poorly or there's a lot of stress in the room, everyone in that room, the nurses, the anesthesia provider, the surgeon, are all there to make sure that the kid does as well as they can. And I really do. I am very grateful for, our surgical colleagues that, like, if I have a concern and I voice it, like, they listen to what I'm saying, and they do such a great job of, sort of like thinking about that expertise and that perspective. And I feel like we work in a really good team environment. So that in a way helps with the stress, right? Even though there's a lot of stress going on, you can walk away from those things and feel like, everyone's doing what they can to help with the kid. Um, when I get home, I think it gives perspective for my own kids, that they're healthy and, that it gives, it's like super grateful to say, like, my gosh, like, here, it's my pain in the butt kid who's, not listening or whatever. It gives me a little bit more grace, I think. Um, but I think having interests outside of medicine isn't really important for me personally. Like playing music is like a big part of who I am and what I do. Um, and that's, I think, something that I've been lucky to have an opportunity to do over the last several decades of my life. Um, my brother plays bass in the same band, so having that connection is really cool to have, connection with him, and just having something outside of what we do. It's great.
And I will put this in the show notes as well, but I would love for you to go ahead and name check your band
Oh yeah, of course.
and talk a little bit about it.
Sure. So I play in a band called Moonshine Drive. It's a Cincinnati-based bluegrass band. We've been playing for probably 15 years now. But we play at bars and festivals around Cincinnati. Um, we play a lot at Arnold's and other kind of city fests around. So you can check us out on moonshinedrive.com or Spotify, Amazon Music, YouTube, whatever it is. But we have a lot of fun, and yeah, it's it's really cool to be able to like just like totally escape and play music and have a like a totally different part of my life that I can think about.
What about you for stress management? What are your thoughts?
Yeah, I mean, I think before we started recording, so I have a second phone as well, and I keep my work stuff on that second phone. So that's one thing, is sort of
Mm.
trying to compartmentalize work and life. And so when I cross the threshold of my house, it's just my life now. It's hopefully not work. And then, I love to be out in the garden, and I love to take care of, and even just pulling weeds. Sometimes just being out in the front yard pulling weeds, where it's like, I can't mess this up. It's just pulling weeds, I can only make it better. Or cooking. I can't mess, well, like, you can mess up
I was
cooking,
going to
but
say, I
you
have
know,
messed up both of these
yeah.
things. you
Sometimes,
leave you leave the whole root in there. That can be
um,
tricky.
but at least it looks better, right, on the surface. So just anything. I mean, I like to listen to music on the way home. I sit in traffic on the main interstate here in Cincinnati for 45 minutes every day, and I turn off my brain, listen to music, and try to just be Joe when I walk through the door and not the anesthesia attending. And I think doing that, fortunately, anesthesia is a field where you can mostly leave things at work, right? Most of the clinical burden you can leave at work. But we're kind of fortunate in that regard. But I did choose a career where I felt like it was easier to do that
Yep.
versus, primary care physicians are on the hook constantly for, messaging and with patients and parents, and we're fortunate enough to not always have to deal with that stuff. And that's very helpful for me too.
One of the things that I think is great about Cincy Children's is the pediatric fellowship program. Um, we send a lot of our residents to do fellowship uh, with you guys, and they always end up being amazing. Uh, Even previous guest of the podcast, Yusuf Raslan, now over at Simple
Ah,
Children's. Um, my question is, I wonder if you guys could talk a little bit about the fellowship that you guys have over there, how many fellows you take every year, because it's quite a big
it's big,
program,
yeah.
uh, and maybe just a little bit of information about it.
Yeah, so we have 12 fellowship spots.
Which is enormous.
It is large. My residency class, I think, was 14 or 15, so it's almost as big as an entire residency class. I think we have room to accommodate more, but just historically, traditionally, we've kept it at 12, which seems to be a nice large size for the fellowship program. It's a 1 year fellowship, just like the rest of the fellowships. There are opportunities for advanced fellowships in chronic pain and cardiac, as well as some non accredited fellowships that we offer. And so, folks who want to do peds cardiac spend that extra year as super fellows, as we call them. But it's a great experience, and I think it's a unique experience because in anesthesia residency, you're off service. Sometimes you're in the emergency department, you're on OB, you're in the ICU. With a pediatric anesthesia residency, you're doing OR anesthesia every day, which I really enjoyed. I always really enjoyed OR anesthesia, and so it was just a good experience. Mark and I both did the fellowship, obviously different times, but it's just good to do OR anesthesia every day and take care of kids. I think it's one of the best experiences from a fellowship standpoint. We're very clinical focused, and there are certainly opportunities to do research or academic things while you're a fellow, but it's a busy year, and you're really there to get that clinical experience and repetition.
Yeah, I'll echo that, and also say that when you rotate with us, even if you're not interested in pursuing a fellowship in pediatric anesthesia, I think that we will make you a better anesthesiologist, because of the attention to detail, some of the things we had talked about before, how you make decisions in the operating room, how you plan. I think they're all skills that, really being in kind of in focus and in touch with the patient is really important. But yeah, our fellowship is super strong. Like, we have Jeremy Deers, the program, or the fellowship director now, and does a great job advocating for the fellows. And the experience that we're able to give them is top notch. It's a very clinically focused year, and I feel strongly that that's very important. You're not going to spend a lot of time in a lab or doing research projects. You're going to be in the operating room taking care of sick kids, and that's really what you want out of it.
I wonder if either of you would be willing to tell me about a case that you found particularly challenging or memorable that you would kind of use as a case that you would tell a medical student or a resident about to potentially make them more interested in pediatric anesthesia, or perhaps let them gauge for themselves whether or not they'd be interested in pediatric anesthesia.
Um, Gosh, taking care of thousands of kids over the years. It's crazy to think about that. I mean, I think the ones that are most memorable to me are the ones where I have a personal connection with the kid or the family, and oftentimes that comes from knowing them over time, right? So I've taken care of little 2 year olds with hepatoblastoma, and just getting to know the families. I do a lot of anesthesia up in our CBDI clinic. And so,
What kind of
I'm
clinic
sorry,
is that?
CBDI is Cancer Blood Disease Institute. So it's like the oncology clinic. So I take care of a lot of kids who have new diagnosis of cancer in our oncology suite, and seeing families come in with a new diagnosis of leukemia or hepatoblastoma, and just seeing how they process that, and then establishing a connection with them, you know assuring that I'm going to take good care of their kid, and then having that relationship over time, and then seeing them come back for repeated procedures, and how they become sort of adjusted to their new normal is really kind of powerful. um, I will also say that when we take care of kids in the operating room that have really, bad malignancies and things like that, you just feel like you can really rally behind them. Um, and so I've, taken care of kids, like I said before, with hepatoblastoma. And, it's like either for liver transplantation or liver resection, and just seeing how, like all of the things you want out of anesthesia are there. You're putting big lines in, you're doing an epidural, you're doing resuscitation, and then setting them up for success for pain control afterwards. And so those are the types of cases that I think are most gratifying. And then on top of that, getting to see them 3 months from now, 6 months from now, and saying, like, oh my gosh, like this kid is doing really well. They recovered from the surgery, their cancer is under control now. And just having that kind of short term, kind of immediate feedback of like a really cool case, and then also the long term, relationship that you can have with patients.
Yeah, I think the ones that stick out to me are patients who are in the NICU who have congenital diaphragmatic hernias. And usually these moms give birth at our fetal care center, especially if it's a known CDH that's known to be severe that might end up going on to ECMO shortly after birth. So usually the moms are in house, but they're often bedside. But there's a lot of uncertainty with those cases, which I think can make some people feel very uncomfortable, and often everybody's very tearful, especially if it's a severe lesion. But I always just tell the parents that I'll watch your baby closely, and I'll keep them comfortable and keep them as safe as I possibly can during the surgery. And sometimes that's kind of all you can offer. You don't know what's going to happen. Even if they repair the lesion, you don't know if the kid's going to get much better. But those moments where you're offering some sort of comfort, any comfort that you can to the parent, because it's kind of all they've got at that point, those always stick out to me. And that's something I would tell, I think that could make some people run the other direction. Like those that's hard for me, or that's an uncomfortable moment. I don't want to be involved with that. But if that is something that interests you, and then learning how to take care of those, neonates who are very sick, that's someone who should probably consider doing a fellowship.
I really liked hearing you say that you talk to parents about keeping their kids safe and comfortable, because that's something that I actually say every day to my patients. My two jobs, number one is keeping you safe, number two is keeping you comfortable. And everything I do is one of those two things. And I found that a lot of people that I've talked to independently also seemingly have that mantra about keeping people safe and comfortable. Although I don't think that that's necessarily taught specifically. I think that a lot of us just sort of come to that ideal of that's really what we do, which I think is it's really neat to hear other people say it as well.
Yeah, and I guess I don't know. I maybe I've heard other people say that too, but I agree with you. I've never been taught that or told that. But I think when you boil down the specialty, it is those two things, right? And things that are frustrating to people, like NPO times and why do I have to not eat before surgery? I think when you boil it down to those things, we want to keep you safe, we want to keep you comfortable. Everybody understands that, and it makes people feel more comfortable going back to surgery. And sometimes safe and comfortable is all you really have to offer. You don't know what's going to happen with a prognosis or with the development of the disease after the fact. And so say I'll keep you safe and I'll keep you comfortable, and I feel like it at least gives people some comfort in a time that maybe is very stressful for them.
We mentioned stuffed animals earlier and all the different um, toys and such that people will bring back to the OR, the kids will bring back to the OR. Although sometimes we do see adults with stuffed animals over here
Sure. Sure.
that have wanted to bring them back to the OR before, which I think is interesting. Um, my question, though, is what I seem to remember from one of my rotations is for a kid with a broken leg, we would take their bear back with them to the OR, and we would wrap the leg in similar dressings um, that we would the child. And so I'm wondering, do you guys do anything like that? Is there anything like that over at Cincy Children's?
I mean, I think that that is something that is done, yeah, that I've seen before. I'm personally not putting the wrapper around the stuffed animal, but I think it does sort of speak to, um, we're very patient and family centered, and we really try our best to make kids feel okay about what's going on to them. I mean, I remember when I was a kid, I broke my arm, and I have a very vivid memory of going back to the procedure room with two orthopedic residents who put my hand in some sort of contraption and set my arm with no anesthesia. And I also don't remember getting to fill out a patient satisfaction survey back in those days. But like, I don't know, I think that, at the end of the day, we're keeping kids, doing what we need to for them medically, but we go a little bit above that and try to make their experience as positive as possible with it, recognizing that you can't get rid of all sort of, agitating or anxious provoking things, but we make an effort.
Yeah, the nurses and the patient care assistants are really good about that. And
Yeah.
I've seen them, if a kid's getting a dialysis line, they'll put something that looks a little bit like the dialysis line on their teddy bear and put a dressing over it and put the locks on the end of the just so that that kid, that stuffy, I mean, my kid's stuffies look like they've been dragged through the desert for 6 years. They're so dirty, but that's like their thing, right? That's what they always want with them. And if their thing has gone through the same thing they have, I think it does help kids. And if it helps them process things, why not? But yeah, it's usually not me applying the bandages. But at the end of the case, usually the teddy bear's got a little bouffant on and
That's
a
right.
gown and some dressings, and everyone is just taking care of the kid as best they can.
Does a tablet count as a stuffy these days? It probably should.
Yeah,
Yeah.
yeah, you're probably
Actually,
right.
our job is way easier now with tablets.
iPads.
What's your favorite game for kids to play? Do you have one, Joe?
I feel like Fruit Ninja's a good one. It's
Fruit
old,
Ninjas.
but it's good because they just,
Yep.
there's also the one where they're like running on the road or the subway or whatever, and they're jumping. That one's usually good.
Yeah.
The other
Yeah.
day, a kid was playing Mario Run, like the Mario jumping game, and I took it from him and ended up playing it while the resident or whoever put the kid to sleep. And they're like, "Is that for you or is that for the kid?" That's a little both.
I want to see if I can get Fruit Ninja to sponsor the podcast.
Oh gosh, yeah. No, it's super
Free
effective
advertising.
because it gives the kids something to do, right? Like if they're engaged. Every once in a while I'll pull out the driving the car game, and so I'll have them. We have these like pink foam pillows that, I'll give the kid as a steering wheel, and then I'll take the lock off the bed and tell them the story about getting into a car. So their hands are on the pillow, right? And that's a really important. So if the kid's holding on to something else, they're less likely to pull the mask away. And then, you got to go through the whole spiel. Here's the exhaust, et cetera, et cetera. But then you can actually move the bed and shake it around. It's a lot of fun.
These are really great style points to share. I wonder if you guys have any other style points that you want to share about whether it's talking to parents or taking care of the kids that have brought you success in and out of the operating room.
Yeah, I mean, just to be clear, if I have a resident come over and start doing the car game, I'm going to be irritated that they stole my thunder. But no, I think, like I said before, I think you have to meet the kid where they are. You have to think about their developmental stage. Um, for school age kids, asking them if they want to do something is not appropriate, especially if you know that they're going to have to do what you want them to do. Um, Being honest with kids is really important, I think.
Hmm.
Trying to like sugarcoat things too much sometimes is a problem. Kids are a lot smarter than we think they are. Um, I find that the 8 to 12-year age is really interesting to me because those kids know way more than you think that they do, and they think about a lot of things. And so I always ask kids, I care a lot about what your parents are asking, but I like literally talk to the kid and say, "What do you want to know more about? Do you have a question? And like, is there something you're nervous about?" And I tell them, if you are, you know, ask somebody. We can talk about it. And I think that's really important for kids of that age to um, feel like they have some agency in it. And you'd be surprised. I mean, I had a kid once who had YouTubed videos of tonsillectomies, and he was like super interested, and it was really helpful for him to understand like what are they actually doing. I mean, not something I would advise uh, my own kid looking at before surgery, but they know a lot, and I think it's important not to gloss over that.
You should make sure and tell them that they can put that on their ARIS application.
Oh, for sure.
later.
That's right.
I'm familiar with all the steps of a tonsillectomy. No, it's true what Mark said, and I had a kid who was pretty young within the past 6 months or so that he was most worried about waking up during anesthesia, which in the adult world is very common, right? Awareness under anesthesia, but I would have never thought that would have been what he was most worried about, but that's all he cared about. I'm not going to wake up, right? You're not going to wake up. And then he was like, okay, I'm fine. And so sometimes it's things you don't expect that they're like ruminating on. And I know my kids do that too with weird, you're like, what are you thinking about? And then they tell you and you're like, huh, well, we're eating dinner right now. So why are you thinking about that? And
Right.
kids definitely surprise you. And I think Mark's right. Engaging the temptation, I think, is just to engage the parents, but always like getting down on the level of the kid. And sometimes it's literally like if it's a little guy or a little girl, get squatting down and saying, who's this? Who'd you bring with you? And just talking to them and seeing how they interact with you. And that tells you about 90% of what you need to know about how this kid's going to, sort of act when you're doing the induction. But it's hard to teach, but I always try to remind any trainee that comes over is it's sort of a gestalt thing and you'll get used to it, but just talk to the kid, talk to the parent, and you'll start to pick up on those cues.
One of the things that I want to mention based on what you said is that while having a fear of waking up under anesthesia is extremely common.
Yes.
Like you said.
Yeah. It is not common.
It is not common.
I heard that too.
We want to make sure as anesthesiologists that we appropriately tell everybody that waking up under anesthesia is not a
Super
thing
rare,
that you should
right.
be concerned about
No,
any more
no.
than a piano falling on your head
Correct.
while you walk down the street.
That's a great point. I didn't even think of how I worded that. Sorry, listeners.
No, I think that what Joe said too about getting down to the level of the patient is super important. And remember, we have to establish this rapport with kids and families so quickly as and this is not specific to pediatric anesthesia, but in general, anesthesiologists have to establish that rapport very quickly. And so strategies, I think, are, bringing yourself to the level. Like I always sit down next to the kid. When I talk to the family, I'm always sitting at the level of the kid. And I think that's really important just to like position yourself in that way. It's less intimidating, I think. And small talk is fine. But just like being honest with kids, I think is really important. I think that the hardest times for me is when parents are asking you to not tell their children things.
Yeah.
Those are really difficult situations to navigate. And at the end of the day, you kind of have to follow their lead. But I always worry about that. Like if the parents are asking you to withhold information from their child, that can be difficult to sort out.
Well, Mark, Joe, I really enjoyed talking to you, and thank you so much for coming by. This was a great conversation.
Yeah, thank you. Never done anything like this, but it was fun.
Yeah, thanks, John.
Thanks for listening to another episode of Style Points. If you enjoyed the episode, please consider giving us a rating or a review. It helps other people find the show. While you're at it, go look up Moonshine Drive on Spotify and give Mark's band a listen. I specifically recommend the track Gone Again. Check it out. If you have any questions about PEDS Fellowship or anything else we discuss on the show, please email me at stylepointspodcast@gmail.com. We get thousands of emails every day and have a dedicated team of highly paid people to manage the volume. Before you second guess that, I would encourage you to take a deep breath and open your eyes. We are all done.